My talk is on hemocytomorphometry, a case-based approach. So I'll be taking up from where Dr. Anil left, as he rightly said that the modern analyzer is throwing a lot of histograms, scattergrams, and even a lot of flagging that we need to be aware of. And I would go a step further that not only we must train all our technologists on the bench to be aware of them, because unless those guys are aware, sometimes those slides may not reach our table also. So we have to first train ourselves, and then we have to train our technologists also. So we'll try to look at some cases primarily from the histogram and scattergram point of view, and try to see if we can make diagnosis even without seeing the slide or seeing the slide at the last moment. The diagnosis should be clear to us from the histogram and scattergram as much as possible. So this is the scatter plot that Dr. Handu had also shown in his presentation. I'll not talk about it in much detail, although there are three cell lines that I'll particularly want to talk about. One is the HFC, or the green dots above the monocytes. These are the high fluorescent cells, or what you want to call them as the Downey cells, Turk cells, or transformed lymphocytes, virocytes, whatever you want to call them. They are usually increased in viral infections, particularly dengue, and also sometimes in certain lymphoid blasts as well. The next is the immature granulocytes, which are basically nothing but your promyelocyte, myelocyte and metamyelocyte put together. So now they have put a numerical count on it. We can develop our own biological reference interval for both HFC and IMG. And IMG is a useful marker in both diagnosis of bacteremia as well as septicemia. And this third cell line here that is this infected RBC. This is a scatter plot which is between the neutrophil and eosinophil on the scatter axis. And this is usually a diagnosis for the malarial parasite. So this is a very useful flag, infected RBC. So these are three new flags that I just wanted to bring to the notice of people who are not Mindray users. So this is my case study one. This is just a case that came to us about 15 days ago. This is a 36-year-old female, history of fever, ecchymosis and petechiae. So this is the platelet histogram. I think it is very clear to all. This is a case of thrombocytopenia. You can very clearly see from the histogram itself. This is the optical platelet scatter plot. On the y-axis is the forward scatter or the cell size, and on the x-axis is the fluorescence. So this blue and green area together is the area of the optical platelet, and the green portion is the area of the immature platelet fraction or reticulated platelet, whatever you want to call it. Clearly the IPF is very high in this case, so obviously there is some peripheral platelet destruction going on in this case. So these are the indices. As expected, the platelet count is 23,000, the IPF is 33, and this is monsoon season. So the most common diagnosis that we would entertain would be a dengue. But surprisingly, the clinician was also very confident about it being dengue. The NS1 was negative, the IgM was negative, the IgG antibody was negative, and the RT-PCR was also negative. And the clinician was very sure it is dengue. It was being managed with dengue, and it had already come through 3 labs to us. So previous labs, one had given dengue NS1 equivocal on the ELISA. So hence the dengue diagnosis was continuing. So this is the WBC scatter plot that I showed earlier. So this blue area here is the area of the neutrophil, but there is another area juxtaposing here. So when we rotate the cube, these two blue areas get discerned out. So this blue area between the neutrophil and the eosinophil is actually the area of the infected RBC or the malarial parasite. The machine also throws out a flag here. If you can see at the top right, it has given a flag of the infected RBC. So once that flag was there, I was very sure that this is now malaria, and I started to search for it. And believe me, even on the rapid card, it showed a very faint line. It had very low parasite density. And I had to search for more than 5 minutes to find the ring form. But this flag is very sensitive. It has got a sensitivity of 99.3%. and a specificity of 99.7%. So once you start looking for this flag, you will end up identifying a lot more malarial parasite than you would otherwise do. So the diagnosis was very clear before I even looked at this slide. It was Plasmodium vivax malaria with thrombocytopenia. This is next case. This is a 32-year-old vegetarian female. At a routine checkup with her physician, she complained of fatigue over the past 2 months. So as you can look at the RBC histogram, it is very clear it is showing dimorphic, predominantly macrocytic anemia. The platelet histogram is showing some giant platelets because it is not touching the baseline at the upper discriminator. And if you look at the this blue area here, this is the area of the optical RBCs. And this pink area here is the area of the reticulocyte. From left to right, it becomes more immature. So clearly, as the reticulocyte is going all the way till the right, the IRF or the immature reticulocyte fraction is definitely higher. This is the optical RBC scatter plot. On the y-axis is the volume or the MCV, and on the x-axis is the hemoglobin concentration. So the area below is the area of the microcytosis and above is the macrocytosis. Left is hypochromia, right is hyperchromia. This center square is the normocytic normochromic. So as you can see, most of the scatter is in the area of the macrocytosis. So just from the visual impression, we know that this is macrocytic anemia. Now I'll show you the indices. So this is based on my theory of light scatter. When we have isovolumetrically sphered RBC as is there in a fluorescent analyzer, the low angle scatter shows the volume and the high angle scatter shows the hemoglobin concentration. So these are the indices. Hemoglobin is 9.7, MCV is 116, RDW is 20.8 and IRF is 22.3. So reticulocyte is normal but the IRF is high. This is typically what is there in an untreated megaloblastic anemia. But the strange part is that the folate, serum folate, RBC folate and B12 were all normal. So what could it be? Okay, I'll show you one more finding. We did an active B12 or the holo TC for this patient, it was low. So 50% of patients with B12 between 150 and 300 can actually turn out to be B12 deficient, because what we are measuring as B12 is the total B12, but most of it is in the bound form. Whereas what is important is the active or the free B12 or the holo transcobalamin, which is nothing but your active B12. So whenever a patient is between 150 and 300 and you are still suspecting megaloblastic, you should try and do an active B12 before envisaging or a more invasive procedure like a bone marrow. So yes, this was a case of megaloblastic anemia due to B12 deficiency. But the important point is that we are trying to diagnose it even before seeing the slide, even before trying to look at the indices, just from the histogram and the scatter plot. So this is the next case, 8-month-old child, fever, progressive lethargy and dark red urine for 24 hours. So this is the RBC histogram, otherwise pretty much okay, but a broad base, probably a high red cell distribution width. This is the rect scatter plot. As you can see that there is a lot of reticulocytosis and there is movement all the way to the right, so probably high IRF also. Now this is an interesting scatter plot. This is called the WNV scatter, where on the y-axis is the forward scatter or the cell size and on the x-axis is the fluorescence. So this blue area on the right, greenish blue, is the neutrophil. And here just between this pink and blue area, sometimes there is a yellow area which is called the basophil. And just on the left, this pink area is the area of the nucleated RBCs. So you can differentiate nucleated RBC, basophil and neutrophil in this scatter plot, which you cannot so much do on the bigger scatter plot. So clearly there are a lot of nucleated RBCs in this case. Just for your reference, this is how a WNV scatter plot would look. On the right will be the neutrophils, in the middle the yellow area will be the basophils, and to the left the pink area is the area of the nucleated RBCs. So we know there is reticulocytes, we know there is nucleated RBCs. Now these are the findings. Hemoglobin was 4.5, MCV 89, RDW 23.8, marked anisocytosis, TLC was elevated, reticulocytosis was there, and look at the nucleated RBC. 18 per 100 WBC. So we worked up for the hemolytic anemia. There was unconjugated bilirubin, haptoglobin was less. There was blood in the urine chemistry and the G6PD was pretty low. So this was basically a case of G6PD deficiency. Case 4, this is a 6-year-old female, history of viral fever 2 weeks ago. So this is the platelet histogram. Very clear that this is a case of thrombocytopenia. This is the optical platelet scattergram. Clearly the green area is very high, so there is very high immature platelet fraction. Obviously there is peripheral platelet destruction. These are the indices. Platelet count was 9,000, IPF was 39.3. The machine could not calculate the mean platelet volume, obviously a lot of giant platelets. But the dengue antigen and the antibodies were both negative. The doctor considered an ITP, treated with corticosteroid, and after corticosteroid the platelet increased to 97,000, IPF 4.8, IPF went down from 35 to 4.8. And this is the scatter plot of the later case. The platelet histogram is normal, and even if you look the area of the IPF, the green area has also reduced significantly. So this is the case of ITP. Fifth case, this is a dengue known case, NS1 positive case. I am just trying to follow the same patient from day 3 to day 8 to show how high fluorescent cells and immature platelet fractions can be used as a prognostic marker. So this is this case day 3, the platelet count is 171, HFC is 0.2. So the normal range at our lab for high fluorescent cell is 0 to 0.4. This is pretty much normal. This is the scatter plot. The platelet histogram is normal. And these small green dots here on top of the monocyte, these 3-4 green dots, these are the area of the HFC or the high fluorescent cells. Next day, platelet count went down to 82,000, HFC jumped to 3.7%. So HFC has become high. Usually on day 4, the HFC increases in a dengue case. If you look at the scatter plot, those green dots have increased, that area of the HFC above the monocyte, and the platelet histogram is still pretty much okay. Day 5, platelet count went down to 38,000, HFC jumped to 12.6. So you can see that the platelet histogram is now showing some spiking. It is not as good as it was in the earlier 2 days. And of course, the HFC scatter plot is more dense than the previous 2 days. Day 6, platelet count 43,000, HFC is 13.1. The platelet histogram is all over the place, and HFC is still having prominent intensity. Day 7, it could not discern the HFC because sometimes HFC get merged with the monocyte, the machine is not able to differentiate. But the platelet count is kind of plateaued at 57,000. Again, this is a gray scatter plot. The machine is not able to differentiate monocyte from HFC, and the platelet scatter plot histogram is still not quite okay. This is day 8. The platelet count has significantly increased to 99,000 and HFC has gone down. So as the platelet count increases, the HFC comes down. You can see on the scatter plot, the HFC scatter plot has reduced in intensity and the platelet histogram is near normal now. So 2-3 things that I want to show this case for. IPF or the immature platelet fraction begins to rise as there is peripheral platelet destruction in dengue patients. The HFC increases from day 4 of the onset of fever in all dengue patients. The platelet recovery usually begins within 48 to 72 hours of the peak IPF values, and there is a HFC intraday jump of 3 to 4 times after the onset of fever. And this is our own algorithm in monsoon season. It's not gone wrong because a febrile patient in monsoon season with platelet count less than 50,000, IPF more than 20% and HFC greater than 5%, all 3 conditions running concurrently, is almost certainly dengue irrespective of the serological status. Now this serological status can also be very tricky. NS1 is usually positive for the first 5 days and sometimes antibodies take day 7, day 8 to come. So the day between day 5 and day 7 is always a very tricky day where antigen could also be negative and antibody may also not have come. So these kind of algorithms are very useful in such scenarios. Sixth case, this is an asymptomatic male patient who came for us for his annual checkup. So this is the WBC scatter plot. You can see that most machine could not discern the cell line, but there is a very intense scatter on the left of the eosinophil, mostly in the myeloid region. But the next scatter plot will give it away. That yellow region in that WNB scatter plot is the area of the basophil. So we know that there is basophilia, there is myeloid cell lineage. You are almost thinking CML right now. These are the indices. The counts are 2,33,000. There is thrombocytosis. There is 3% basophilia. The immature granulocyte, which is myelo, metamyelo, promyelo together are 51%. Our normal range is 0.6. And we diagnosed it as CML in chronic phase. The BCR ABL was also positive. This Dr. Handu has already discussed, so I will not discuss again. IMG. So this is the case of CML in chronic phase. BCR ABL was positive. The reason why I showed is that even before you look at this slide, just by looking at the histograms and scattergrams, you already know the diagnosis. This is case 7th. This is a 77-year-old lady who had come to us with history of weakness, vomiting, altered bowel habits, and pain and gum swelling for the past 15 days. So this is the differential scatter plot. As you can see, the maximum intensity is in this monocyte region, which is the pink region, followed by a lot of intensity in this blue region above the neutrophil, which is the area of the immature granulocyte. So definitely there is monocytosis in this case. This is the WNB scatter plot. There is no basophil, so we know that there is CML is pretty much ruled out.
So we have just 2 minutes for the talk.
This is my last slide. Yeah. So the platelet histogram showed thrombocytopenia. And there is a blast flag on the right hand side. This is my indices. Hemoglobin is 8.5, MCV is 107, WBC is 12,000, platelet count 28,000. Monocytosis was 32% and 12% were blasts. So we reported it out as AML with myeloid differentiation, and on flow and NGS it came out to be as AML M5. So as we've seen that most of these diagnoses we are able to make even before viewing this slide. Just by looking carefully at the histograms and scattergrams, we are able to conclude a lot of diagnoses and sometimes pick those that the clinician not even asked for, like in that malarial parasite thing. The clinicians were very sure it is dengue. So my takeaway message would be again that train yourself to look at a lot of data that is coming out of these machines, just as Dr. Anil said. But more importantly, train your technical staff as well, because the more trained they become on the histograms and scattergrams, the better smear reviews you are going to get and more better diagnosis that we all will be able to make. Thank you for your patience, and if there are any questions, I'll be glad to answer.
Thank you, Dr. Sundeep, for beautifully illustrating your message through case studies, and I think it's extremely convincing in terms of how these abnormal populations or normal populations, when they become abnormal, throw light on the probable cause of those changes. I just had one query before I throw this talk open for discussion. In the case of ITP, was the patient put on treatment? If so, was it without doing a bone marrow? Was it based on only the CBC results?
Yeah, so it was done without putting the patient on bone marrow, sir. And the reason is being that the IPF was very high. In a case of hypoplasia, the IPF is less than even normal range. But here the IPF was 30-40%. It almost gives away the diagnosis of peripheral platelet destruction.
Fine. That's good. So any more question? Anybody? Yes.
As Sir said, the MCV and megaloblastic anemia does not correlate. I've seen cases like MCV is normal, 82, 87, but vitamin B12 level is low. So how do we explain that? Even the hypersegmented neutrophils also will not be there.
Could you be louder, ma'am? I couldn't get the question.
I think, let me explain. I think you are asking that you can get megaloblastic anemia without the MCV being high. and even the early sign of megaloblastosis in terms of hypersegmented neutrophils is not visible. Is that what you are saying? So the
She's
question
saying that megaloblastic anemia without MCV.
high MCV.
So there can be two things. In a diamorphic anemia also sometimes the MCV can be normal because there is simultaneously microcytic anemia. Otherwise also the neurological symptoms of B12 deficiency come at a much higher level. Usually at a level around 300 you can start manifesting the neurological symptoms. Whereas to manifest the hematological symptoms usually you need to get down to levels of 100, 150. So I don't know whether you're talking about hematological manifestation or the neurological manifestation.
Hematological.
So most likely then it is a case of diamorphic anemia because
Yeah.
MCV could be normal there.
That's right. That's what is the answer. If you have a normal MCV, and but then you need to look at the RDW and simply look at the red cell histogram. So that will tell you whether the patient has a dimorphic anemia, wherein the patient will have low vitamin B12 and or folic acid and iron as well. So depending on that, I think you can make a diagnosis. So it's not uncommon to see dimorphic anemia which have normal MCV, yet the hemoglobin is low, and people don't pay attention to the RDW, and then you miss them. And also, a lot of us don't look at the red cell histogram. So you don't have to get into very high-tech analyzers for that. Very simple analyzers. If it gives you a good red cell histogram, you will be able to make out the diagnosis of dimorphic anemia from the red cell histogram and looking at the RDW.
Classically, the RBC histogram will usually have a bimodal peak.
Any more questions?
I have a question. Yeah, about megaloblastic anemia too. Have you seen that in these cases that are borderline between 150 and 200, that the methylmalonic acid or the homocysteine can be helpful or not?
I didn't get it, sir. Could you?
If you have seen in these cases that are borderline between 150 of B12 and 200, if the methylmalonic acid or the homocysteine are useful in these cases.
So methylmalonic acid is also can be used, but it is a very difficult test to produce in an automated laboratory environment. HoloTC is available on a lot of automated platforms and on the CLIA platform. So HoloTC is more reproducible from a laboratory point of view. But MMA can also be used. Methylmalonic acid can be used.
Doctors. Homocysteine.
Sir, similar to this.
So hyperhomocystinemia is usually seen more with folate than with B12 deficiency.
So on the other hand, we have a high MCV, but vitamin B12 and folic acid are normal, and picture is in bone marrow biopsy and aspirate is megaloblastic. So you told about active vitamin B12.
Yes, ma'am.
What is about that? Little details.
So active B12 is nothing but your holotranscobalamin. It is the active or the free form of the B12.
How
So-
to test that?
So that can be tested by using HoloTC or active B12 on certain analyzer. If I am permitted to take names, so maybe you can do on Abbott or Roche platform.
So, Dr. Suri, there are two questions which are online, so I'm just reading them out. One is, are there studies regarding reference values for the hematology parameters which you spoke about in your talk? So, this is the first one.
So
Yeah.
you want to take the second also, sir?
No, I think you finish with the first one.
Yeah. So each lab must develop their own biological reference interval. Don't copy my biological reference interval and start using in your lab because most of these parameters are based on fluorescence. And the fluorescence dye between different manufacturers is also different. Even within the same manufacturer, different instruments have got a different algorithm. And last but not the least, sometimes some of these parameters are dependent on ethnicity. So what is applicable to my part of the city may not be applicable to your part of the country. So develop your own biological reference interval and then only begin reporting these parameters.
So, the other question which is there, which you had actually kind of touched upon during your presentation, but I'm just reading it out because, again, online there is a need for this to be answered. And it says, is there any correlation with presence of large lymphoid cells or the high fluorescent cells in the analyzer with dengue serology or NS1 testing?
Yeah. So high fluorescent cells or downy cells, whatever you want to call them, are present in a lot of viral infections and even some lymphoid malignancies as well. But in a post-monsoon season or just this time about August to September, October, if you see HFC more than 5%, in a viral infection scenario, it is usually not other viral infections. It is almost certain to be dengue.
Thank you. I think that answers the question.
If there are no more questions, we'll be closing. But before that, just a point to answer your question. If you have a macrocytic anemia, which is not supported by a lab evidence of B12 folic acid deficiency, anyway, you have to think of myelodysplastic syndrome. Because at the end of the day, after therapy and all that stuff, a lot of cases, they turn out to be that. So it's just from general knowledge that I'm sharing with you for the benefit of the rest of the audience. I think we'll stop here with
Thank you,
Shamma's
Dean.
permission.